Well, an important cause of abnormal bleeding is thrombocytopenia. Thrombocytopenia means a decreased number of platelets in peripheral circulation. This is an important cause of abnormal bleeding. The normal platelet count in peripheral blood is 150,000 to 450,000 per microliter. And when the count goes down below 100,000 per microliter, we call it thrombocytopenia. When the platelet count goes below 50,000 per microliter, induced bleeding can occur. And induced bleeding means excessive abnormal bleeding on excessive abnormal bleeding with small trauma, small surgery. And when the platelet count goes below 20,000 per microliter, spontaneous bleeding can occur. And spontaneous bleeding means bleeding into the skin, bleeding from the mucosal surfaces, bleeding from mucous membranes, without any trauma, without surgery whatsoever. And causes of among the causes of thrombocytopenia, first of all, there may be decreased production of platelets from the bone marrow, and the conditions in which there is decreased production of platelets from the bone marrow may be aplastic anemia, in which all the series developing in bone marrow are suppressed. That is the WBC series, RBC series, and platelet series. So it's one of the causes of thrombocytopenia. Similarly, in leukemias or in disseminated cancer, when the blast cells or the cancer cells they go on increasing in the bone marrow, and the normal cells of the bone marrow go on decreasing and decreasing, the it leads to time comes when it leads to very much decreased number of platelets in the peripheral circulation. Next is about drugs. Some drugs like thiazides and anti-cancer drugs, they affect on the bone marrow and decrease the number of platelets in the peripheral circulation. Some infections like HIV and measles, they decrease the production of platelets in the bone marrow. And similarly, megaloblastic anemia. In megaloblastic anemia, production of all types of cells in the bone marrow are decreased. The second group of causes uh, which lead to decreased production of bone marrow is decreased survival of platelets. Well, in this case, the fact is alright, raw material is available and the product is being produced, that is, the platelets are being produced normally in the bone marrow, or rather in conditions uh, more and more platelets are produced in the bone marrow, but their lifespan in the peripheral circulation is decreased, so they are being destroyed in the peripheral circulation very earlier, before their expected lifespan. So there is they lead to decreased number of platelets in the peripheral circulation, producing thrombocytopenia. Idiopathic, in this group, there are idiopathic thrombocytopenic purpura. Some drugs like quinidine, heparin, sulfur drugs, they lead to decreased production of, they lead to increased destruction of platelets in the peripheral circulation. Some infections like HIV and infectious mononucleosis. Then there is DIC. DIC means disseminated intravascular coagulation. Well, this is a condition in which widespread thrombi are formed in small vessels throughout the body. Then there is thrombotic thrombocytopenic purpura and microangiopathic hemolytic anemia. These are the conditions which lead to decreased survival of platelets, and in this way they lead to thrombocytopenia. And the third important cause is a cause of thrombocytopenia is sequestration of platelets in a large spleen. That is, hypersplenism is one of the causes of thrombocytopenia. Before uh, going further, we should know some terms, importantly two terms which will be used again and again while talking about bleeding diathesis. One is petechiae. Petechiae means small, usually 1 to 3 millimeter large, red, non-blanching macular lesions which are caused by intradermal capillary bleeding. Like this, small pinhead size 1 to 3 millimeter lesions, reddish areas like this and like this. While purpura are larger, typically raised lesions resulting from bleeding within the skin. Petechiae and purpura both do not blanch. So larger areas of reddish discoloration, which sometimes is produced by confluent petechiae, it will be called purpura, like this and this. Well, idiopathic thrombocytopenic purpura or ITP is the condition which we are going to discuss today. It may be idiopathic, that is, no cause is known whatsoever, or it may be immune thrombocytopenia. And immunologically mediated destruction of platelets may be associated with these conditions: SLE, that is systemic lupus erythematosus, AIDS, some viral infections, and by the use of certain drugs, uh, they secondarily lead to immune thrombocytopenia. That is, in these the conditions, some antibodies are produced or some immune mechanism is involved in producing thrombocytopenia. So it will be called secondary immune thrombocytopenia, but true idiopathic thrombocytopenia is the condition in which no such cause is known whatsoever. About idiopathic immune type, there is the real idiopathic thrombocytopenia, the real ITP. No associated, it is not associated with any disease, and its pathogenesis involved production of autoantibodies against platelet membrane glycoprotein 2b3a complex. Well, 2b3a complex is a complex of glycoprotein in the membrane of platelets, like this, Well, this is the lipid bilayer membrane of platelets, plasma membrane of platelets, and these are the glycoproteins. These are the glycoproteins. Glycoprotein 1b, this is glycoprotein 2b3a complex, 2b3a complex, and on the right side glycoprotein 1a. They have all three glycoproteins, they have different functions, and the normal function of glycoprotein 2b3a complex, it is involved in aggregation of von Willebrand factor or stabilizing von Willebrand factor, while glycoprotein 1a is involved in adhesion of platelets to the adhesion of platelets to the endothelium. Well, these antibodies, that is antibodies against 2b3a, glycoprotein 2b3a complex, they are of IgG class. They are present in plasma and on the platelet membrane. And when antigen antibodies have combined, the antigen antibody complexes, they are present on the membrane of platelets, and when these platelets they pass through the sinusoids of spleen, they are caught up there and they are destroyed. So sensitized platelets, they are destroyed in the spleen, and this is the mechanism of destruction of platelets in the peripheral blood. I repeat it again, that is autoantibodies are formed in against 2b3a complex of platelet membrane, and antigen antibody reaction takes place, and sensitized platelets, that is platelets which are coated with these antigen antibody complexes, they are caught up in the spleen and they are destroyed there. Well, morphology of the disease in peripheral blood, what we will see and what we will find in peripheral blood is thrombocytopenia. That is, the platelet count in the peripheral blood will be decreased lower than 100,000 per microliter. There will be features of associated disease. Features of associated disease may be there if it is the secondary immune thrombocytopenia. Well, it looks like this on the peripheral blood. This is the photomicrograph of peripheral blood under the microscope. Well, you can note that very few platelets are there. The platelet number is decreased on the peripheral blood film. Similarly, here, very rare 1 or 2 platelets are seen in this peripheral blood film. And in the bone marrow, in this condition, in the bone marrow, there is increased or normal number of megakaryocytes. That is, the megakaryocyte proportion is normal or it is increased in number. That is, the platelet production in the peripheral blood is increased, or at least it is normal. Some immature forms of macrocytes with large lobulated single nucleus may be there in the bone marrow, and these features, these findings, they indicate there is increased thrombopoiesis in the bone marrow. The clinical features of this disease: the disease is more prevalent in females, and females of less than 40 years of age. The onset is insidious. Slowly, disease comes on slowly. There is bleeding into the skin, into the epidermis and the mucous membranes, and in the skin we'll note presence of petechiae, that is pinpoint hemorrhages into the epidermis. The usually less than 3 millimeters in size. They are more in dependent parts of the body, and when they become confluent, ecchymosis occurs. That is large map-like areas of radish discoloration. There is long history of bleeding from nose or gums. There is more bleeding into soft tissues after little trauma. There may be melena, hematuria, bleeding into the mucous membrane, bleeding from mucous membrane of GIT will lead to the presence of altered blood in stools, which will be called melena. There may be hematuria, that is the presence of blood in the urine. There may be menorrhagia, that is increased bleeding during menses when platelet count is decreased to a very low level. Subarachnoid hemorrhage or intracerebral hemorrhage can occur with its own consequences. The spleen in this condition, in this disorder, in this disease, spleen is not enlarged. Spleen is not enlarged. uh, these all are the findings of ITP of any origin. And to prove it to be autoimmune type, that is primary idiopathic thrombocytopenic purpura, we have to demonstrate the presence of antiplatelet antibodies, that is antibodies against 2B3A glycoprotein complex. And we will have to exclude all secondary causes of thrombocytopenia. There is a condition called acute ITP. Well, the ITP in adults is comes on slowly, but acute ITP, its pathogenesis is the same. It is the disease of childhood. Male-female ratio is equal. The onset, that is the onset of purpura, is abrupt usually after some viral infection. Its onset is not chronic, not slow. It's abrupt onset, and usually it is self-limited. It resolves in 6 months, and about 20% of patients they go on having thrombocytopenia and go into the phase of chronic ITP. Well, thrombocytopenia and idiopathic thrombocytopenia is the condition in which the platelet number is decreased in the peripheral blood, and due to decreased number of platelets, there is defective hemostasis, and there is excessive abnormal bleeding with little trauma. And if the count is very low, the spontaneous bleeding can occur. But there are bleeding disorders related to defective platelet function also. Well, that is, in these conditions, the platelet number may be normal. Platelet number in the peripheral circulation, peripheral blood may be normal, but there is bleeding diathesis, there is abnormal excessive bleeding due to defective platelet function. Well, these conditions, they are rare. Platelet number, as I told you, normal, but the function is defective, and so in these conditions the bleeding time will be prolonged. Bleeding time will be prolonged. But the platelet number will be normal. Prothrombin time will be normal. APTT, that is activated partial thromboplastin time, will be normal. Uh, in this in this condition, only the bleeding time will be prolonged due to defective platelet function, but the platelet number, the prothrombin time, activated partial thromboplastin time, they all will be normal. This condition is of two types. It may be congenital or it may be acquired. It may be congenital or it may be acquired. And congenital platelet function defects. In this group, we have Bernard-Soulier syndrome. Bernard-Soulier syndrome, it is an autosomal recessive disorder, and in it there is deficiency of a glycoprotein complex 1B1X, and the receptor for in it in this condition the receptor for von Willebrand factor, which is essential for adhesion, is lacking, and so there is defective platelet adhesion, and by virtue of this defective platelet function there is abnormally excessive bleeding with little trauma. The second condition, thrombocytopenia, this is also autosomal recessive disorder. In it, there is deficiency of glycoprotein 2b3a complex, and it leads to defective aggregation of platelets. So, the platelet plug formation when a blood vessel is severed in cut vessel, in place of cut vessel, the aggregation of platelets does not occur, the platelet plug is not formed, which leads to excessive abnormal bleeding with little trauma. And a third one, uh, condition in this group is the storage pool disease. In storage pool disease, there is defective release reaction, there is deficient prostaglandin synthesis, which leads to decreased aggregation of platelets, and defective platelet plug formation, which leads to abnormal excessive bleeding. Uh, then there is a second group, acquired function defects of platelets. Uh, Aspirin, the drug aspirin, that is salicylic acid, it inhibits the cyclooxygenase enzyme, and so it blocks the cyclooxygenase pathway of arachidonic acid metabolism in inflammatory mediator production or immunity mediator production. So prostaglandins are not formed, and the thromboxane is not formed, and due to this deficiency bleeding time is prolonged. So using this action of aspirin, the aspirin is administered to heart patients, to cardiac patients, which leads to decreased platelet adhesion in these patients, and the required result of this aspirin administration to cardiac patients is, and that is decreased adhesion of platelets, decreased thrombi formation. The second condition is uremia. In uremia, that is in conditions of raised urea level in the blood, there are produced several abnormalities of platelet function. Several abnormalities of platelet function are produced, which lead to prolonged prothrombin time. So in this condition, there is little increased excessive bleeding. Well, now we go to the bleeding disorders due to abnormalities of clotting factors. Well, in the outset, I told you that, well, we'll take it in the next lecture. Thank you.